everyone. I am Prashant Agrawal. On the behalf of ADLE, I would like to welcome Dr. Amit Khurana, our guest speaker, Dr. Tufan Kanti Doloy, the eminent panelist, participants, and Dr. M.B. Agrawal, sir. I would like to welcome all of you in this informative webinar. As of you know, that ADLE is dedicated to oncology and one of the fastest growing oncology company in India. It is because we always believe in patients' first approach. We provide high quality medicines at the cost effective rates. Not only this, we also develop new drug delivery systems. Not only in India, but we are expanding ourselves in international markets as well. We are having a rich portfolio in hemato-oncology segment with the brands like Carfimib, Bidan, HTEM, MDSO, Pagalasjan, and MDS. Plus, recently, we have launched Eltrambopac, that's the Estrom, and very soon in this month, we are coming up with Nilotinib with the brand name of Kylonib for your patients. Thank you very much. And now I hand over the proceedings to Dr. Amit Khurana.
So, thank you, Mr. Prashant Agrawal. Well, very good evening to all of you. Today, our guest speaker for the day is Dr. Tufan Kanti Doloy from Kolkata, and he's going to lecture us on how do I approach a case of pancytopenia. This webinar is brought to you by Mumbai Hematology Group, supported by ADLE and managed by Perfect Square. I thank Mr. Ashutosh Shukla and team ADLE Oncology, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Tufan Kanti Doloy from Kolkata, all our discussants who are themselves eminent hematologists, and you participants for sparing your Saturday evening. Tomorrow, that is Sunday, 20th August 2023, from 11:30 a.m. onwards, we have a webinar on recent advances in the mechanism and treatment of immune thrombocytopenia by our guest speaker, Dr. Priyanka Chauhan from Lucknow. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Abhijit Baheti from Dinanath Mangeshkar Hospital, Pune, Dr. Aniket Mohiti from Jahangir Hospital, Pune, Dr. Ankur Ahuja from AFMC, Pune, Dr. Atish Narayan Rao Bakane from New Era Hospital and Research Center, Nagpur, Dr. Dilip Kohokar from Lokmat Bhavan, Nagpur, Dr. Dhyaneshwar Upase from Wakad, Pune, Dr. Ketan Modak from National Cancer Institute, Nagpur, Dr. Kunal Chatani from Nagpur, Dr. Lisa Bulsara from Avinash Cancer Clinic, Pune, Dr. Mahesh Mandolkar from Dinanath Mangeshkar Hospital, Pune, Dr. Navit Tamboli from Dinanath Mangeshkar Hospital, Pune, Dr. Neha Ganju from Ganju Hematology Clinic and Hospital, Nagpur, Dr. Nishat Thakate from SCG NCHRI Cancer Center, Nagpur, Dr. Neeta Munshi from Ruby Hall Clinic, Pune, Dr. Pankaj Dwivedi from National Cancer Institute, Nagpur, Dr. Rahul Arora from Nagpur, Dr. Riya Balikar from Kingsway Hospital, Nagpur, Dr. Samir Bellingkuri from Dinanath Mangeshkar Hospital, Pune, Dr. Sandip Bartake from Bharati Vidyapit Medical College, Pune, Dr. Sriram Kane from Dr. Kane Hospital, Nagpur, Dr. Sweta Banka from Nagpur, and Dr. Vishwadip Khushu from AIIMS, Nagpur. Now it's a time to introduce our guest speaker for the day, Dr. Tufan Kanti Doloy. Dr. Tufan Kanti Doloy is Professor and Head at Department of Hematology, NRS Medical College and Hospital, Kolkata. He is ex-alumni of Department of Hematology, AIIMS, New Delhi, and did his DM in clinical hematology. He has published over 120 papers in peer-reviewed international and national journals and over 180 publications in conference proceedings as abstracts. He is an organizing secretary of Hope Asia 2019, highlight of past European Hematology Association Congress, EHGCon, BASHCon, and several other national and international CME and conferences. He is the editor of the Journal of Hematology and Elite Sciences and reviewers of several national and international journals. He has been awarded several gold medal, distinction, received several orations, successfully conducted several projects, international and national clinical trials, over 20. He is a member secretary, Institutional Committee for Stem Cell Research, ICSCR, NRS MCH, and member of Institutional Ethics Committee, IEC, of NRS Medical College, IIT Kharagpur, Raiganj University, and Institute and Health and Family Welfare, Government of West Bengal. Today, he is going to lecture us on how do I approach a case of pancytopenia. Well, thank you so much. Dr. Tufan sir is yet to join us. So he has given us a recorded video, but he'll be soon joining us live during the discussion. So we will play a recorded video for you in front of you. Well,
Dr.
thank you
Amit,
so much.
I am already joined. I am there.
Oh, you are there, sir. You want to start as live or should I join as your recorded video, sir?
Recorded.
Recorded video, fine, sir. So Kalpesh, can you just go for a recorded video?
Good evening to everybody, and thank you the Mumbai Hematology Group giving me the opportunity to speak on the subject of the pancytopenia. And I like to specially thanks to Professor M.B. Agarwal and also Dr. Amit Khurana. So today evening I will be speaking on how do I approach a case of pancytopenia. You know, the pancytopenia is very common entity. And the learning objective of my speak will be the what is pancytopenia and what is the etiology of the pancytopenia and what is the stepwise diagnosis of this pancytopenia, and lastly the how do I approach the patients with the pancytopenia. The talk will begin with an interesting case. Here is a 29-year man presented with local hospital with a 1-week history of intermittent fever. There will be drenching night sweat and there is a reduced appetite. There is a left upper abdominal pain that has been exacerbated by the inspirations, and there is no history of any weight loss. There is a cough, dyspnea, nausea, diarrhea, rash, or any mouth ulcer, arthalgia, ocular, or the urinary symptoms. But in the history, there is 8 years back, patient has a episode of fever, has a joint pain, there is a positive of the ANA report, and the oral glucocorticoid were given after 2 months with the resolution of the symptoms. There is no family history of the autoimmune and the clotting disorders. But unfortunately, the father have been died due to the aggressive natural killer cell leukemia. On examinations, patient is alert and oriented. There is no weakness or sensory deficit. The temperature is 38.2 degrees centigrade. BP and the pulse is normal. The heart sound and chest is clear. There is no hepatosplenomegaly. There is no lymphadenopathy, and there is no abdominal tenderness or the enemas, and there is no rash or the joint erythema or any swelling have been found. On investigation, patient has anemic, the 8.5 is hemoglobin. The WBC is 2,500 with the 62% of the neutrophil, and platelet count is 87,000, and reticulocyte count is 0.3. The ESR is 88 in the first hour, and the APTT is normal. APTT is high, that is the 75.4 to 32 second is the control, and the PT is normal. And the corrected value with the mixing with the normal plasma is 61.3. So on investigation further, patient has a sodium of 127, potassium is 3.9. The urea, creatine, liver function test, and the serum amylase all are the normal. The C-reactive protein is 0.8, and the blood culture have been sent. To summarize the case, my patient has a fever with the pancytopenia along with the low reticulocyte count. So there is a lot of differential diagnosis will be there in this case. But if we consider the tidbit of these patients, apart from the pancytopenia, the APTT prolongation is there, and it has been not corrected by the normal plasma. And also there is a positivity of this the ANA, and there is a history of this oral ulcer also. So keeping in the mind of this history of the patients, the differential will be your bacterial infections, the viral infection, particularly the CMV and the Epstein-Barr virus infections. That might be the leukemia also, and also the aplastic anemia, sometimes the malaria infections, and the acidic with the lupus nephritis. In these patients, from the history and the investigation, it is obvious that patient has been suffering from the SLE with the lupus nephritis or the lupus inhibitors. And the interesting thing is that what do you mean by the pancytopenia? The pancytopenia is defined as the when the hemoglobin is less than 13.5 male and the 12 gram per in female, and the leukopenia has been defined as the less than 4,000, and the platelet is less than 1,50,000, and the severe pancytopenia have been defined where the absolute neutrophil count will be less than 500, the platelet count will be less than 20,000, and the corrected reticulocyte count will be less than 1%. So if all the three lineages are involved, we call the pancytopenia. The common causes of the pancytopenia, mainly there are three important issues is there. There is impaired productions, there is the peripheral destructions, and there might be the both the things together. That is called the impaired productions and the peripheral destruction is there. So in terms of the impaired productions, the common cause you deal with the plastic anemia. It might be the acquired cause, might be the congenital, that is called the inherited bone marrow failure syndrome. Sometimes the bone marrow infiltrative disorder, particularly the malignancy, the primary myelofibrosis, the granulomatous disease, and the metabolic disorder might be the etiology. In terms of the nutritional deficiency, particularly the vitamin B12 deficiency, the folic acid, the copper deficiency is also common. And obviously, in elderly, the myelodysplastic syndrome is the common differential diagnosis of the people with pancytopenia, where there the impaired productions is there. In the etiology of the peripheral destruction, we call the autoimmune hemolytic pancytopenia, or there the splenic sequestration is there. If both the mechanism had been added together, that is called the impaired productions and the peripheral destructions, the PNH will be the common etiology. Then come to the SLE, the drugs, the leukemia, or there is sometimes the HLH, or sometimes the THGVHD, the rare infection that can also give rise to the pancytopenia. So if you go to the etiology wise, the pancytopenia causes decreasing productions of the both the bone marrow failure syndromes included. Along with the bone marrow failure syndrome, the other etiology is also there that have been, I already told you, the MDS, the megaloblastic anemia, there is storage disease. Sometimes the chemotherapy and the radiotherapy also causes the transient decreasing productions of the blood cell. Immunomediated destructions. Apart from the drugs, there is the Evans syndrome, the immune pancytopenia, and the autoimmune lymphoproliferative syndrome. This is the common entity that then people can present it with the features of the pancytopenia. In the non-immune mediated mechanism, particularly the sequestration by the periphery, the common is the chronic liver disease with the portal hypertension, we call the hypersplenism. Also, there is myeloproliferative disorders and the hemophagocytic syndrome. And in terms of the combination of the mechanism, that is called the immune vis-a-vis non-immune, and sometimes a little bit of the infection-related pancytopenia, we call the combined etiology. The common is the SLE, the rheumatoid arthritis, the Felty syndrome, sometimes the tuberculosis infections, CMV, the Epstein-Barr virus, and the HIV infection. So these are the common etiology that people learned up with the pancytopenia. To categorize the pancytopenia new onset, the primary it is idiopathic and the inherited or called congenital, and the secondary pancytopenia is due to have some etiology, particularly the infective marrow productions and the autoimmune disease and also the peripheral destructions. In terms of the Indian settings, particularly in case of the children, this paper have been beautifully described the etiology of the pancytopenia in the children. In the non-malignant etiology, it is around 44%. Malignant etiology is 21%, and around 21% of the cases there is a iatrogenic cause of the pancytopenia. So if we consider the malignant and the non-malignant separately, in terms of the non-malignant, then the megaloblastic anemia is the top priority, and in the children, the acute leukemia and the GMML, then followed by the lymphoma is the top priority. So in terms of the children with the plastic anemia and also the acute leukemia, this is the common entity we should not forget in our day-to-day clinical practice. So this series has been clearly tell us that the distribution of the various causes of the plastic anemia, the commonest is the megaloblastic, then come to the plastic anemia, there is a subleukemic leukemia also there, and there is other disease that can give rise to the features of the pancytopenia. This is common in case of the adult business. So comparing to your children, the etiology of the adult is different. So it's starting from the megaloblastic to the storage disease and the multiple myeloma should be considered as a differential diagnosis of the pancytopenia in adult. So there is a different series is there in Indian setting. There is a 5 series is there. In the 5 series, there the common thing is that plastic anemia, the megaloblastic anemia, the hypersplenism, and the leukemia. These are the top causes of the pancytopenia in the adult in terms of the Indian settings. There the Western literature is there. Their etiology is slightly different from the Indian settings. So in terms of the pancytopenia etiology, is also varies according to the age. If the people presented with a pancytopenia in the children, then the viral infection is the top priority, particularly the Epstein-Barr virus and the CMV infection. Then come to the bone marrow failure syndrome, plastic anemia, acute leukemia is the top causes of the pancytopenia in children. In adult, the megaloblastic anemia, the plastic anemia, the collagen vascular, then come to the acute infections and also the acute leukemia is the common causes of this adult onset pancytopenia. In the elderly, this etiology is slightly different. Here, the leukemia becomes a second priority. The first priority is the megaloblastic anemia, then myelodysplastic syndrome, and also the chronic liver disease-related hypersplenism, metastasis are the common cause of the pancytopenia. So, etiology of the pancytopenia is varies according to the age of presentation of the pancytopenia. So to work out the causes of the pancytopenia, the history is very, very important, examination, and also the investigations. This is the very important to try to find out the causes of the pancytopenia. In terms of the history, the detailed clinical history, medication is very important. Sometimes drugs induce pancytopenia, the chemotherapy, the radiotherapy, sometimes the recreational drugs, the environmental factor, sometimes the dietary history, particularly the vegans, they have a more predisposition to the vitamin B12 and the folic acid deficiency. The investigations, the blood count, the CBC, and the examination of the peripheral smear is very important to try to find out the etiologies. Then subsequently, you have to do the bone marrow examination to find out the etiology of the pancytopenia. In terms of the history, in children and adults, there is a little bit variation is there. In children, there is a non-specific viral infections, autoimmune disorder, and the leukemia is the common. And also, we have to find out the history of previous pancytopenia, plastic anemia, there is innate bone marrow failure syndrome, sometimes the cancer, the liver disease, and connective tissue disease. These are the common finding in people presented with pancytopenia, particularly in case of the adult and elderly. But you should not forget that in terms of the chemotherapy and the radiotherapy, they usually causes transient pancytopenia. And sometimes the mild pancytopenia is usually seen in case of the non-specific viral illnesses. Sometimes the weight loss and the anorexia may be the underlying cause of infection. You know, there is a tuberculosis, and also in the weight loss is extremely seen in case of the visceral leishmaniasis. That has to be keeping it in the mind. Apart from that, you have a cytopenia, related symptoms might be there. If the patient has a thrombocytopenia, there may be the mucosal hemorrhages. Anemia, there will be shortness of breath and edema and fatigue. Infection, there might be due to the secondary to the neutropenic fever. This is commonly seen in case of the extreme pancytopenia, or we call the severe pancytopenia cases. Examination is very important. You have to be very cautious by examining the each and every steps of the patient with pancytopenia, because with history and the physical examination clinch the majority of the patients of the line of investigations of the patient presented with the pancytopenia. And another thing is that the pancytopenia is not a clinical entity. It is the laboratory entity that has to be found out from the history and also the clinical examinations. You have to carefully look for the petechiae, the purpura, and the bruising, particularly in the oral cavity. You have to also examine carefully for lymphadenopathy, the splenomegaly, sometimes the bony tenderness, the joint tenderness, joint inflammations, and then come subsequently the specific organ systems has to be examined very carefully. There is the example that if the patient has a jaundice with pancytopenia, you should consider the liver disease first. Sometimes patient has a multiple episode of the the conjunctival hemorrhages, there might be the fundal hemorrhages, there might be the wet purpura. So if these things is there, so your platelet count is very low, that is less than 10,000. If the patient has a gum hypertrophy, you should always consider there is acute leukemia, particularly the AML. And also if the patient has a candidiasis, in the oral candidiasis, then possibly this neutropenia is long-standing, the duration is more than 2 weeks, that lead to the immunosuppression, and patient have been suffering from this candidiasis. If the child has a lot of the dysmorphic features, particularly there is a rudimentary thumb, there will be absent radius, there might be the depigmentation, the hypopigmentation, that might be the cause of inherited bone marrow failure syndrome in people with the pancytopenia. Usually the middle-aged elderly, there is a butterfly-like face is there, there will be photosensitivity, there will be the paleness oral ulcer, then allows to think that patients have been suffering from the SLE or the autoimmune disorders. And you have to examine the liver and spleen carefully, because if the spleen is very big, that is called the massive splenomegaly, and also the liver is there, then you should always think that my patient has a hypersplenism, and we try to find out the etiology of the hypersplenism. Sometimes the radiology will help to find out the abdominal problem, particularly the ultrasonography, the CT scan of the abdomen, chest, pelvis, and MRI. And nowadays, the PET-CT is the important tool to try to find out the etiology of the pancytopenia, particularly the lymphoma or some unknown infection causes. That hotspot we can find out from the PET-CT scans. In terms of the children, particularly in case of the inherited bone marrow failure syndrome, we have to be specific for the history and also the family history. Particularly in case of the children, if there is a failure to thrive is there is a history of cytopenia, there is easy bruising, there is infection, there malabsorption, the maldigestion and developmental delay, you should suspect that inherited bone marrow failure syndrome is there or not. If there is a family history of malignancy, if the family history of the cancers, there is pulmonary fibrosis, if any member have been suffering from the congenital bone marrow failure syndrome, then our suspicion should be the more in terms of the inherited bone marrow failure syndrome in particular type of the patients. And sometimes the examinations also give clue for the diagnosis of the inherited bone marrow failure syndrome, particularly in case of the children. If the patient is short stature, has a congenital anomaly, there is dysmorphic faces, there is abnormal skin pigmentations, there will be nail dystrophy, sometimes there will be the skeletal and the limb deformity, the renal deformity, genitourinary cardiac deformity, cleft lip, cleft palate, developmental delay. That is the multi-system involvement, and you should always suspect that my patient has been suffering from inherited bone marrow failure syndrome or not. And the more important is that sometimes this phenomenon can start at very long back, and you can find out the IUGR, you can find the low birth weight, and also there is a history of the macrocytosis, there is a prior history of the hypercellular marrow that clinch toward the diagnosis of the inherited bone marrow failure syndrome. So in terms of the clinical evaluation of the people with the children, that history and the physical examination is very, very important. Then subsequently the complete hemogram, there is a reticulocyte count, there is a bone marrow aspiration biopsy, and the routine, the CBC, LFT, urea creatinine has to be done. But important thing is that we try to exclude the inherited bone marrow failure syndrome, not only from the details history, examination, and the family history, but you have to look for the other testing also, particularly the chromosomal breakage study from the peripheral blood, the telomere length measurement from the peripheral blood, and sometimes the additional testing, particularly the testing with the fetal hemoglobin, sometimes raised in people with inherited bone marrow failure syndrome. Then you have to consider the other etiology of the children also, particularly the viral infection, which is very common in case of the children, and also the immunological marker, particularly the ALPS is very common in case of the children. So you have to consider the flow cytometry, you have to look for the T cell subset of the patient to diagnose the particular type of the pancytopenia etiology in case of the children. After the suspicions, then we have to order for the few tests, particularly in case of the DBA. In DBA, you have to consider the erythrocytic adenosine deaminase activity. There is a telomere length in case of the dyskeratosis congenita. And the more important thing is that you have to also consider the Fanconi anemia. Then you have to consider the chromosomal fragility testings, and also subsequently the genetic testing has to be done. If you suspect the HDS, then the the enzymes has to be assay, particularly the pancreatic isoamylase has to be assay, and also the trypsinogen assay has to be done. Nowadays, there the NGS technology is available to find out the type of the inherited bone marrow failure syndrome. So after the confirmations of the bone marrow biopsy of the hypocellular marrow, you can order for the NGS and try to find out the any mutation that related to the inherited bone marrow failure syndromes. So for the lab evaluation of the pancytopenia, you have to be judicious. And your history, the physical examinations, and your the basic investigation will guide you that what might be the subsequent test has to be done. So simultaneously writing the 100 test is not becomes judicious. So you have to be very cautious for writing this test, because you have to judicially by routine investigation, then subsequently the specific investigation, you have to confirm the diagnosis. So the specific testing has to be done to pinpoint the particular type of the pancytopenia. Here is the one of the algorithm for the approaches of this pancytopenia. If the patient has a pancytopenia in the CBC, then this patient has to be needs urgent evaluations, and the peripheral smear has to be examined by the expert pathologist or the hematopathologist. Then depending upon your situations, then you have to try to rule out the liver function test by liver disease, the vitamin B12, folic acid, the coagulation, the viral serology and autoimmune profile. And then you have to also try to rule out the PNH and inherited bone marrow failure syndrome. And then you have to do the bone marrow aspiration and the biopsy. In the same setting, if it considers of the etiology that related to your the leukemias, related to the inherited bone marrow failure syndrome, you should always send the cytogenetics, or sometimes you can sending to the immunophenotyping also flow cytometry for diagnosis of the acute leukemia. This is the another approach that the hematologist should follow to find out the etiology of the pancytopenia. The first foremost thing is that you have to find out the pancytopenia. The first history has to be taken. There is a rule out of the drugs and the toxin. Particularly the drug is very, very important. If the drug etiology have been ruled out, then you have to look for the initial workup, particularly the peripheral smear, the iron study, the ESR-CRP, the electric reticulocyte count, and the LDH has to be there. If the patient has a macrocytosis, in this scenario, then you have to go to the MDS and also the megaloblastic, and also the in terms of this the aplastic anemia entity. If there is no macrocytosis, then additional testing, particularly the Coombs test, the vitamin B12 testing, you have to be done. You have to also look for the serum protein electrophoresis, the HIV screening, and USG of the spleen. And this author have been given the NG sequencing also, but this is a doubtful, this is the controversial issue. So from this investigation, we can find out there is a conjunctive disorder, particularly autoimmune and the splenic sequestration, and there is peripheral destruction and the impaired productions, particularly in case of the PNH, the hematological malignancy, the HLH. So in this scenario, you have to do the bone marrow aspiration, the biopsy, and the flow cytometry also. In terms of the production disorder, these are the very, very important thing. Production disorder, maybe the nutritional, maybe the non-nutritional also. In terms of the nutritional cases, then particularly the history of the eating disorder is very, very important, particularly the young children and the adolescents girl. Sometimes in case of the middle-aged people, the obese patient, they did the bariatric surgery, you have to take the history, malabsorption syndrome, they are the inadequate intake, particularly the fast food intaker and also the alcoholism. So in this scenario, you have to investigate for the vitamin B12, iron and the mineral. In terms of the non-nutritional, you straightforward go to the bone marrow biopsy. If the bone marrow biopsy, you have to send along with the cytogenetics and the FIS. Depending upon that, you can diagnose the plastic anemia, the inherited bone marrow failure syndrome, and also you have to consider the other primary hematological disease. But the most important single tool for the diagnosis of the etiology is still the peripheral blood smear examination by the good hematologist, hematopathologist, and pathologist itself. But for the reason, you need good preparation of the peripheral smear. From the good preparation of the peripheral smear, we can able to find out the plenty of the etiology, the clinch toward the diagnosis of this, the cause of the pancytopenia. Then subsequently, we have to order for the bone marrow examinations. And the important thing is that you have to do the bone marrow aspiration and the bone marrow biopsy together into the same procedure. And the bone marrow biopsy has to be done beautifully, because your marrow elements, the adequacy of the sample is becomes very essential. Try to find out the etiology of the pancytopenia. There is a different needle, there is a different techniques is involving for the bone marrow aspirations and the biopsy, and the common methodology of this doing the bone marrow biopsy is the biopsy needle. The disposable biopsy needle has to be used, and the majority of the cases the cannula is there, and this cannula is become slanting. So when you enter the bone marrow, it will cut it, and the biopsy will be enter in your needle. So majority of the cases, the people are using 11 gauge, there is a 13 gauge. Sometimes in case of the obese patient, we are using the 18 gauge needle for find out the better specimen in case of the bone marrow biopsy. So bone marrow aspiration, bone marrow biopsy has to be done together, and from the bone marrow aspiration, you can send the cytogenetics, you can send the immunophenotyping. Sometimes you can send the culture also, particularly the mycobacterium. Sometimes there is CMV, and there are other rare infections, particularly in case of the bacterial infection, you can send from the culture tube during the bone marrow examinations. So if your material is adequate, then you suspect the different bone marrow disorder. Then only you can ask the pathologist or hematopathologist to give the concrete diagnosis, because you have to send the adequate material for the diagnosis of the bone marrow, particularly in case of the pancytopenia. So there might be the hypocellular bone marrow, there might be the cellular bone marrow, there might be the hypocellular marrow with the cytopenias. And in terms of that, the biopsies becomes very, very important. Biopsy not only give the cellular infiltrations, but also give the rust, particularly the ellipse, abnormal localization of the immature precursors, and sometimes you can find at the stain also. We can do the immunohistochemistry also in your reticulocyte staining preparations. So the bone marrow aspirations and the bone marrow biopsy has to be done very beautifully and very carefully to find out the adequacy of the sample. Your particle will be the good, there will be the wide spread of the smear, then you can find out the fat species and the cell in between your bone marrow examination. This is the example of the normal bone marrow. This is the example of the severe bone marrow hypoplasia. There is only fat is there. There is a little bit of the blood element here in case of the aplastic anemia. This is the example of the hypercellular bone marrow. There is a bone marrow packed with the different cells is there, but this adequacy of the sample becomes very, very important. So depending upon the cellularity, depending upon your morphology, you can clinch toward the diagnosis of particular diseases. If there is a people as a hypocellular bone marrow is there, so in the hypocellular bone marrow, then there is acquired plastic anemia, there is Fanconi anemia, there is myelodysplastic syndrome, the MDS, ALL, and the lymphoma and the myelofibrosis will be there. In terms of the pancytopenia with the cellular bone marrow, then there will be the primary marrow failure disease. There is the secondary systemic disease has to be there. And in terms of the cytopenia, sometimes the rare infection, particularly in case of the Q fever, the Legionella, anorexia nervosa, the mycobacterium, the starvation, that can also give rise to the hypocellular marrow with cytopenia. So these things has to be interpreted in context of your proper history and also the examinations. So if the people has a cellular bone marrow, what might be the differential diagnosis? If there is a hypocellular, so our diagnosis is toward the production defect, particularly the plastic anemia. If you have a cellular marrow, then there will be the primary bone marrow disease, maybe the secondary systemic disease is there. In terms of the secondary systemic disease, there is a systemic lupus erythematosus, the hypersplenism, the vitamin B12 folic acid deficiency, there is alcohol, and there is other rare etiology might be there. In terms of the primary marrow disease, the MDS, the PNH, the myelofibrosis, and also the bone marrow lymphoma and the hairy cell should be keeping in the mind for diagnosis of the etiology of the pancytopenia. If you consider that my patient has a pancytopenia with a definite cellularity of the bone marrow biopsy, and you have been beautifully looked for the morphology, then you have to order for the specific test to pinpoint the particular type of the diagnosis. Then you have to order for the chromosomal breakage study, particularly the stress cytogenetics, for the Fanconi anemia. You have to order for the immunophenotyping, cytogenetics, and the lymph node biopsy to find out the lymphoproliferative disorders. You have to order for this particularly different types of the immunoelectrophoresis in the multiple myeloma. You have to also order for this your flow cytometry or the flare for the diagnosis of the PNH, IgG and the IgM from the CMV infections, and also sometimes the Epstein-Barr virus, now that the genetic testing can be done, or also the IgG, IgM testing has to be done to find out the Epstein-Barr virus related etiology. Sometimes, particularly the local areas, sometimes in the particular pockets areas, the leishmaniasis must be common, must be the commonest etiology of this, the pancytopenia. You have to keep in the mind of particular endemic zones. So in that situation, you can order for the serum ELISA, RK39, and also you can do the bone marrow aspiration, try to find out the LD bodies. Sometimes, in particular in case of the elderly, there may be elevation of the PSA will be there if we suspect there is a prostatic malignancy that can metastasis to the bones. So the battery of the test has to be done before reaching in a diagnosis. But your diagnosis should be precise. You have to be use the technique judiciously to find out the different etiology of the pancytopenia. So the simple algorithm is that you have the history and the physical examination. The drug history has to be there, inherited cause to be there. And the important thing is that if your examination there is spleen and liver is there, this patient is not suffering from the plastic anemia. Usually a plastic anemia, the spleen and the liver, spleen and the lymphadenopathy is totally absent. Then you have to order for the CBC and the peripheral and reticulocyte count. You have to look for the blast and the dysplasia. You have to try to exclude the AML and the MDS. Then you have to order for the bone marrow aspiration and the biopsy, particularly the percentage of the blast from the aspirate. Biopsy, there is fibrosis, there are blast clusters, and there are immature localizations, and you can do the immunohistochemistry from your bone marrow biopsy. Then if patient has bone marrow syndromes, then usually we order for the peripheral cytogenetics, particularly if it is less than 30 years, less than 50 years of the age, because the case report up to the 50 years of the age is there to find out the any Fanconi anemia is there. Sometimes the Fanconi anemia is stress cytogenetics is there. There will be no phenotypic abnormality. And other way around also. Sometimes patient has everything is normal, but stress cytogenetics might be the positive. But if the patient had the inherited bone marrow failure syndrome in mind, then you can order for the next gen sequencing, try to find out, try to rule out the inherited bone marrow failure syndrome causes of this the pancytopenia. But you have to remember that I've been again confirming that the bone marrow biopsy is very essential, has to be done each and every cases of this pancytopenia to find out the different types of the etiology of this pancytopenia. And my approaches of the pancytopenia is very simple. So I have to take the proper history, particularly the age is very, very important, because you know the children, adult and the elderly etiology is different. Duration of the illness and associated symptoms becomes very, very important. Then you have to examine the patient properly, the GI examination. Then come to the systemic examination has to be done carefully. Starting from the head to toe examination is very, very important. Then after the examination, keeping in mind of your provisional diagnosis, then I order the CBC and the peripheral smear and reticulocyte count, the first line. Along with sometimes you order the Coombs test, the LDH and serology, vitamin B12, the folate level, the LFT and the P time, and also the ANA level in the first line of the testings. After the seeing of the report, if we are unable to diagnose the proper etiology, then we have to go ahead with the bone marrow aspiration biopsy, the cytogenetics, the immunophenotyping has to be done to diagnose the people, whether the patient has a plastic anemia there or not, whether the patient has other etiology there or not. After that, I try to find out the specific etiologies of this pancytopenia, particular etiology of the hypoplastic marrow, particular etiology of the cellular marrow, by doing the special investigation to confirm the diagnosis of the etiology of this the pancytopenia. Ladies and gentlemen, the take-home messages of this the pancytopenia is that we know the combination of the anemia, the leukopenia, and the thrombocytopenia together we call pancytopenia. The initial diagnosis is result from the CBC. I already told you pancytopenia is not a clinical diagnosis. It is the diagnosis from your CBC, the complete blood count. And you should also know that the transient pancytopenia is due to the chemotherapy, due to the radiotherapy, and the etiology of the pancytopenia are drivers in the children, the elderly, and also the adult. But yes, the common things should be keeping in the mind first, particularly the non-specific viral infections, the megaloblastic anemia, the aplastic anemia, the acute leukemias, the hypersplenism. These are the common 5 etiology of the pancytopenia. But if you have a severe pancytopenia that wants immediate and the urgent investigation, we have to be referred to the hematologist, and particularly the specialist for the blood disorder has to be referred. And important thing is that to find out the etiology of the pancytopenia, the history, thorough history has to be examined, to be taken. Then come to the physical examinations. After your examination, then you have to do the CBC and the peripheral smear. That has to be carefully examined by the trained pathologist and hematologist. Then you have to order for the bone marrow aspirations, bone marrow biopsy to find out the cellularity of the marrow, to find out the etiologies of the marrow. But the more important thing is that your the good history, the physical examination, and the initial investigation will guide you to reach the specific diagnosis of the etiology of the pancytopenia, and then you have to be ordered the specific test to find out the cause of this pancytopenia. With this, thank you very much for the patient hearing. If you are know more about the assessment of the pancytopenia, you can find out the BMJ best practice, the assessment of the pancytopenia. With this, thank you very much for the patient hearing, and have to be happy for answer some questions and the query. Over to the organizer, please.
Thank you, Dr. Tufan sir, for that wonderful lecture as always. Always worth to listen to you and very, very good to listen to you. Thank you for joining us and spending your time this Saturday evening. And now I request all our discussions to please put the raise hand sign so that we can start our question answer session with Dr. Tufan sir. So in the meanwhile, I have a question for you, sir. 84 years old male who comes to you with just a pancytopenia with a hemoglobin of 10, WBC count of 2,800, with a lymphocytosis of 56%, neutrophil of 30%, a little bit of monocytosis. Bone marrow absolutely normal. There are no other abnormal cells seen. Cytogenetics normal, and the cytopenia persists last 6 months. Dysplasia only in megakaryocyte lineage with a hypolobated megakaryocytes. NGS normal, cytogenetics normal, no hepatosplenomegaly, no lymphadenopathy, and the cytopenia persists for 6 months per patient is asymptomatic, non-transfusion dependent. What would you label this cytopenia as, sir?
I think this is a very, very interesting case, and this is a very complex history. And you know, sometimes each and every patient is different. So you have to thoroughly take the history and the examination and subsequently guide for this the investigation of cause of this cytopenia. And sometimes the rare disorder, we should also think for that. Patient has a dysplasia. If the dysplasia is significant, then we can think for that it might be related to the myelodysplastic syndrome, particularly in case of the elderly. And another thing is that if the dysplasia is there in the elderly, sometimes there is a CLPD, particularly the encased leukemia and the lymphoma in elderly. This is also the common differential diagnosis we should keep in the mind. And also the hairy cell leukemia, this is another entity sometime in adults, particularly in the very elderly, that might be indolent course also. That is,
We'll come to you.
mind your history and the examination. I think the other battery of the investigation has to be done to find out exact cause of this cytopenia.
Thank you, sir. Dr. Neeta Munshi, your question, please. You're muted. You're muted, ma'am. You're muted, ma'am. Can you please unmute yourself? Yeah. No, we can't still, because we cannot hear you, ma'am. No, ma'am. We cannot hear you. So I think there is some problem with your audio, ma'am. Or you can type your question in the chat box. In the meanwhile, we can take a question from Dr. Samir Malinkri, sir. Dr. Samir Malinkri, your question, please.
Yeah. Hi, Tufan. Thank you for an exhaustive lecture. My question is related to hypersplenism. Say, if you have hypersplenism, uh, any condition such as, say, portal hypertension, you've got a splenomegaly and you've got pancytopenia. I just want to know there is conflicting literature regarding what exactly happens in hypersplenism, whether it's actually just sequestration and the part of the and the platelets and the white cells, etc., which are sequestered in the spleen, they are a part of the exchangeable pool of platelets and white cells. Is that the case, or are they actually destroyed? So I want to know what your understanding is. And also in a hypersplenism, say you have pancytopenia, which is normally asymptomatic, you generally don't bother too much about treating it. But what are the situations where you actually would like to increase the platelet count or white cells? So for example, if the patient is posted for surgery and you have a low platelet count, what is your target platelet count? How do you improve it? What do you do? Do you give drugs, or do you transfuse? How do you manage?
Thank you, Dr. Swami, for these wonderful questions. Because the hypersplenism is very difficult entity. Because sometimes it is very difficult to find the etiology also. So in terms of the hypersplenism, usually we know there is a peripheral cytopenia and the bone marrow is the cellular. So there is something in between that. There is a trapping of this blood cell. And this is true for the thrombocytopenia. We know there is 30% of the platelet pool is within the spleen. So if the spleen is massively enlarged, so there is a thrombocytopenia. But here is the catch is that usually in case of the hypersplenism, the platelet count is very less likely fall below the 30,000 or the 20,000. It is usually around the 40,000 to 60,000 or above that. If the patient has a bleeding related to your thrombocytopenia, usually the hypersplenism etiology is less likely. In terms of the cytopenias, means the WBC count is low and also the hemoglobin low. Exact etiology is very different to difficult, whether it is due to the pooling effect or due to the something in between that you are exactly pointed out this issue. But if the spleen is very high, so there is a trapping of the WBC also. Another important thing is that in terms of this, the low hemoglobin in the setting of the hypersplenism, we have to think of the other entity and other etiology also. So in terms of the treatment of this, the thrombocytopenia and in the setting of the surgery, sometimes it is very difficult. And depending upon the major and the minor surgery, we have to give the different threshold for the platelet count. Usually in case of the surgery, the minor surgery, the 30,000 is platelet is sufficient. If it is the abdominal surgery, the more than 50,000 is sufficient. Sometimes in case of the CNS surgery and other ophthalmological surgery, you have to give in the 80,000 or the 1 lakh above. So depending upon the surgery, this the platelet count is there. Another important thing is for the treatment of the hypersplenism to raise the platelet count.
Tufan sir, we have lost you.
Can you hear me now?
Just a minute, ma'am. I just come to you.
Yeah. Consider hello, I am audible?
Yes, sir. Now you're audible.
So in that scenario, that sometime we can do the partial splenectomy also. Sometimes there is splenic embolizations, particularly the selective embolization, and also the partial splenectomy sometimes become efficient to decrease the platelet count and also the WBC count. As Dr. Somir is rightly pointed out, the splenectomy is basically a difficult LDT. Exact etiology may not be found, and also the explanation of all these consequences is sometimes very difficult. Over to Dr. Amit, please.
Thank you, Dr. Samir sir, for the question. Thank you, Tufan sir, for the answer. Dr. Neeta Mushi, are you ready with your question now?
Yes. Yeah, hi.
Please go.
Good evening, and thank you for a wonderful, very comprehensive talk on pancytopenia. Being a pathologist, I'm very glad that you did point out the importance of a peripheral smear, But I just wanted to add a couple of points that if you could include reticulin stain in the peripheral smear as well. That is one, because it is very important. Mainly this is for the residents actually, that, add reticulin stain in the peripheral smear as well. And in the bone marrow, you did insist on the reticulin stain. But one point that I had was that in megaloblastic anemia, which is one of the commonest causes of pancytopenia, we see a hypercellular marrow. So although we have a hypo and a cellular marrow, in megaloblastic anemia, we could see a hypercellular marrow. And then that really helps us with the diagnosis of megaloblastic anemia. So these were the two things that I just wanted to add. Thank you so much.
Thank you, ma'am. Dr. Sandeep Bartake, your question, please.
Good evening, Dr. Tufan. It was a really nice lecture. Thank you for that. I wanted to ask about children specifically. One of the important causes of pancytopenia, which can be easily diagnosed, can be osteopetrosis, especially in infancy. And because they will present with pancytopenia and organomegaly. And by just doing a infantogram, you can diagnose that. So that was my comment. And secondly, how have you come across myelofibrosis in children as a cause of pancytopenia, and how have you dealt with it?
Thank you, Dr. Sandeep, for this wonderful question. I think you rightly pointed out, sometime in case of the infancy and the young children, osteopetrosis might be the important etiology called the marble bone disease. During the bone marrow aspiration, we usually suspect that this might be the etiology. And in terms of this, the myelofibrosis in the children, it is a very rare entity. And in my career, I am not came across any of this patient that patient has a severe myelofibrosis, at least the grade 2 or the grade 3 myelofibrosis that lead to the primary disease in the children. But yes, sometimes there is a other etiology like the leukemia that can cause myelofibrosis, particularly the acute lymphoblastic leukemia in the children. They have a little bit of the myelofibrosis along with the leukemias. And interesting thing is that sometimes there are other rare disease, different kind of the storage disease in children. They can present it with pancytopenia also. So as you rightly pointed out, in children, we have to think for the osteopetrosis also. You have to think for the storage disease also. Over to Dr. Amit, please.
Thank you, Dr. Sandeep Bartake. So anybody has any other question to Dr. Tufan, sir?
Sir,
Yeah.
am I audible?
Yes, you are very much audible. Dr. Rahul, please go ahead.
So for aplastic anemias or cytopenias, when we sometimes are unable to diagnose the cytopenia, how helpful is NGS as per your opinion, sir? How does like in the case described by Amit sir, where there was a man with pancytopenia and NGS was normal, and still we declare it an NGS. But sometimes NGS does help. What is your opinion?
Yeah, I think this is again is very interesting question that is very applicable, particularly in case of the children's, because sometimes in the children there is innate bone marrow failure syndrome is there is a pancytopenia or there is a pancytopenia. So in that setting, sometimes you may not have any phenotypical abnormality. So particularly in case of the children, you should do the NGS to rule out the innate bone marrow failure syndrome. So it is in the common algorithm of the pancytopenia in the children. You are absolutely right. You have to do the NGS to rule out the innate bone marrow failure syndrome in children when they presented with the cytopenias. Dr. Amit, please.
Thank you, Dr. Rahul. I saw another question for you. For regarding the pancytopenia because of liver disease, what is your cutoff for platelet transfusion? What is your cutoff for FFP transfusion? And what is your cutoff for blood transfusion in case of pancytopenia due to liver disease?
I think this is the liver disease related to pancytopenia. There is two, three things important thing is there. Sometimes there is alcohol induced. There is a folic acid deficiency. Sometimes there is a vitamin B12 deficiency. Might be the cause of this the pancytopenia. So in this scenario, we have to supplement it. If there is a liver disease that lead to the huge spleen, that is called the hypersplenism. So in that cases, you have to treat like a hypersplenism only. So in terms of the transfusion, as you rightly pointed out, because in case of the liver disease, when there is a portal hypertension is there, sometimes we raise the hemoglobin level higher than the normal threshold. Normally, the hemoglobin we give transfusion around the 7, but in case of the liver disease, when there is esophageal varices is there, you have hemorrhoids is there. In this scenario, I think you should raise the hemoglobin level at least the 9 and the 10 gram per DL. In terms of the coagulopathy in the hepatic disease per se, if there is no bleeding symptoms, there is no.
We cannot hear you, sir. We have lost you. Yeah.
Very difficult to do these things. So, because the only the effective supplementations, this may not be the sufficient enough to treat the coagulopathy in case of the liver disease. If there is a bleeding symptom is there, we try to find out the associated abnormality. Sometimes the DIC might be there. Sometimes there is a low factor level might be the contributing factor. So you have to play with this the factor. In terms of the platelet count, as you rightly pointed out, when there is a bleeding, we have to give the transfusion. But yes, my opinion is that in case of the liver disease, with the portal hypertension, we have to raise the platelet is more than 30,000 because there is a GI bleed may be possible due to your varices and due to your hemorrhoids. But this is a very interesting and very practical question, Dr. Amit is asking. Dr. Amit, please.
Thank you, sir. Thank you for that answer. Dr. Diagnostic Upas has raised a question. Can you please comment on the pancytopenia which is related to Gaucher's disease? Pancytopenia due to Gaucher's disease.
Pancytopenia and Gaucher's disease is basically the hypersomnia only. Because in the Gaucher's, the presentation is sometimes there is cytopenia, sometimes there is a neurological problem, and sometimes there might be the pancytopenia. But when there is pancytopenia, we usually suspect there is a related to your massive spleen. But sometimes there is a type 2 Gaucher's and type 1 Gaucher's. They can also present it with anemia also. Per se pancytopenia presentation with Gaucher's without hypersplenism is very, very rare. When there is a pancytopenia in the Gaucher's setting, we should always suspect that patient has some hypersplenism. Dr. Amit, please.
Thank you, sir. Yes, Dr. Neeta, ma'am. Please go ahead.
One question. Have you come across a case where in pancytopenia, it is difficult to differentiate between hypoplastic MDS and aplastic anemia? Because they are very dicey. Both are cases of pancytopenia. So if you have come across any cases, and how have you approached it?
I missed the question, Amit. Can you repeat it?
The question is, how do you differentiate the case of hypoplastic MDS versus aplastic anemia?
Yes, I think again this is a very interesting question have been asked, because sometimes it is very difficult to differentiate from the hypoplastic MDS from the aplastic anemia. As you rightly pointed out, name suggests that we have a dysplasia. If there is a more than 10% dysplastic cell is there, particularly into the erythrocyte, particularly into the granulocytic series, and also a little bit of the macrocytic series, you can think that there is a hypoplasia. And also your cellularity, the bone marrow biopsy cellularity. If the bone marrow biopsy cellularity is less, that not fulfilling the criteria of the severe aplastic anemia, and along with you have a dysplasia, then you have to think that my patient has a sometimes hypoplastic MDS might be there. Sometimes we can also find out there is some abnormal localization also. The ellipse sometimes may be associated with this, but you have to rule out the high grade of the MDS in the setting of this, the high risk MDS, by doing the immunohistochemistry, particularly the CD34 count. Sometimes when the myelodysplastic syndrome progresses to the leukemia, sometimes the bone marrow may be inaspirable, and you can suspect that patient might have hypoplastic MDS. But if you have abnormal localizations, you have abnormal clustering of the blast. So in that scenario, in the setting of the hypoplastic MDS, you should rule out the advanced stage of the MDS because the treatment is different. So the my take-home message is that in terms of the hypoplastic anemia and the MDS, that dysplasia is the very, very important entity. You should be carefully look, particularly the expert pathologists and expert pathologists can able to identify from the aspiration and the biopsy in between the two entities. Dr. Amit, please.
Thank you, Dr. Neeta, ma'am. Another question which has just come up is there is a case of pancytopenia in a 57 years old male, and the peripheral smear shows 15% of large granular lymphocytes. But when the bone marrow doesn't show any LGL, large granular lymphocytes, the flow cytometry is confirmed that it's LGL, but it is CDC57 negative. Bone marrow is cellular, cytogenetics normal, NGS normal, pancytopenia with 15% large granular lymphocytes in a 57 years old male, persistent since last 6 months. How do you approach this case?
I think again this is another interesting case. Similar kind of case I have been also recently came across. Sometimes in case of the LGL, there is an entity we call the indolent LGL. In that indolent LGL group of the patients, there might be the large abnormal cell is circulating with little bit of the cytopenia. Sometimes the transfusion is required, and your immunophenotyping is not typical characteristics of your the LGL. So in that group of the patient will be well fit with the indolent LGLs. So in that group of the patient, if there is a cytopenia, the recurring transfusion, you can play with the steroid and the cyclophosphamide also. But the majority of the cases, if there is no cytopenia, there is no transfusion requirement, you just simply the follow-up patients and frequent monitoring of your the CBC, and sometimes you may repeat your flow cytometry after the 3 months and the 6 months. That this indolent LGL may progress to the LGL, the more malignant LGL. So in that scenario, there is a repeat treatment has to be given. I think this is a very, very interesting thing. Sometimes in case of the very elderly, this the large granular cells may be identified, has to be carefully separate, carefully differentiate from the malignant cases. Dr. Amit, please.
Thank you, sir. Another question from Dr. Bishwa Prakash. In a case of pancytopenia due to chronic liver disease, very well clinically proven radiologically, as well as clinically both, still we need to go for a bone marrow biopsy or no further investigations required in a case of chronic liver disease proven clinically as well as radiologically?
Dr. Amit, basically, this is the clinical scenario, because if you go to the criteria for diagnosis of the hypersplenism, that you have to do the bone marrow aspiration of the biopsy, because your diagnosis should be confirmed, because you without doing the bone marrow, you are not sure that I am dealing with a case of hypersplenism. Sometimes there is other etiology. I told you that vitamin B2 deficiency, folic acid deficiency, sometimes the copper deficiency, that might lead to the cause of the pancytopenia in the setting of the liver disease also. But yes, if your INR is 1.5 and above, you should be cautioned for doing the bone marrow biopsy in the liver disease setting.
Thank you, sir. Another question from Dr. Vishwadip Khushu. When do you suspect heavy metal toxicity in a patient with pancytopenia? And if so, which metals do you test for? 1, 2, 3, 4.
Yes, this is again another fantastic question is that. So in the settings of the pancytopenia, there is copper and the zinc and sometimes the lead. These three is the notorious agent that can give rise to your the cytopenia. And usually the copper and the zinc deficiency, these two is the very, very common. If you suspect it, and if there is occupational exposure is there, if there is other history is not conclusive of the any of the disease, and sometimes there is a associated with other abnormality, particularly the abdominal symptoms, sometimes there is neurological symptoms that might be the cause of your heavy metal things. So this basically the by exclusion, if you suspect that, you should order for the zinc and copper. But sometimes in the arsenic belt areas, we have been came across a lot of the patients, they have a pancytopenia and they are a arsenicosis. So if you have a sitting in the endemic zone of the arsenicosis, so you should order for the arsenic from the hair and the nail also. So basically this heavy metal pancytopenia is entity that has to be excluded after excluding the common diseases. Dr. Amit, please.
Thank you, sir. Another question is that there is a 56 years old male, direct Kuhn test positive of 4 plus, IgG type, hemoglobin of 4, platelet count of 38,000, WBC count is 16,000, bone marrow shows a cellular marrow but with grade 4 fibrosis. ANA is 1 plus positive. How do you approach this case? The cytogenetics could not be done because of grade 4 fibrosis. It was actually a dry tap. Now, how would you approach this case as DCT 4 plus and retic count is 0.5% with erythroid hypoplasia?
I think this is again very interesting case. Particularly one entity we call the autoimmune myelofibrosis hemolytic anemia. So in that group of the setting, that you have the features of the hemolytic anemia, you have the features of the thrombocytopenia, you have the features of the hemolysis, you have the features of the myelofibrosis. So in that group of the patient, usually we diagnose there is an autoimmune hemolytic anemia with myelofibrosis. Because sometimes this entity have been associated with the secondary diseases, particularly the clotting vascular disease, the SLE and the vasculitis. That kind of symptoms may be present along with the myelofibrosis. So I think this is a rare entity, but you should keep it in the mind that if both the things is together, then you should consider this differential diagnosis.
So the question is, how would you go for the treatment for this case? How would you treat this case? We have again lost you.
So
Yeah.
sometimes in that scenario, that you should give the steroid. Usually the 1 mg per kg of the steroid, you can try with that. So if the steroid is not sufficient enough, if you have been excluded the autoimmune profile and the vasculitis profile, then usually the steroid will become sufficient enough. Sometimes we can give the cyclophosphamide also. Sometimes we are treating with the cyclosporine also in this group of the patient, and the more recently that the rituximab has an important role in this group of the patients.
Do we need to test for CVID in this case?
Sorry?
Do we need to test for CVID, combined variable immunodeficiency, in this case?
Yes, particularly in case of the children. If patient has a children, the age group is young, there is a recurrent infection in there is a problem of the skin infection, and also there is a subset of the TB and also immunoglobulin has to be checked, particularly in case of the young children, particularly in case of around the 2 to 5 years of the age, they can present it with similar kind of the things there. So in children, particularly, as you are absolutely right, you have to think for that also.
Thank you, sir. Another question which has come from Dr. Dhaneshwar Upase: how do you deal with persistent pancytopenia in a case of relapsed multiple myeloma, which is of IgG lambda type light chain disease?
So I think it is basically the two important things here. One is the disease related, and another is sometimes there is drug related. In the rare percentage of the cases, we came across that the multiple myeloma can present melanoma in the second.
Yeah. We just lost you, sir. Can you please repeat your answer, because we could not hear you?
So the thing is that sometimes there might be due to drugs, might be sometimes the disease. So in that scenario, particularly the drug-induced pancytopenia has to be in the mind. Particularly the lenalidomide, particularly the cyclophosphamide and the doxorubicin-based chemotherapy, that can give rise to the pancytopenia. De novo multiple myeloma pancytopenia presentation is rare. It is usually around 5 to 10% of the cases.
Thank you, sir. So another question which has come up about leukemic leukemia. Patient has got aplastic anemia and suspected with a very high LDH of 6,000, but bone marrow is hypoplastic. How would you go about that? Bone marrow hypoplastic, LDH of 6,000 with lymphadenopathy. How would you go about this? Pancytopenia. Yeah. Okay. Could you hear my question, sir?
Yeah, I am unable to hear you. Please repeat.
So there is a 15 years male, multiple lymph nodes, bone marrow is hypoplastic, LDH of 6,000. How do you approach this case? Can this be still a leukemic leukemia?
Important, particularly in case of the acute leukemia setting, particularly in the Burkitt lymphoma settings, particularly in case of the leukemia setting.
Yeah, we are losing you, sir, again and again.
Lymphadenopathy. It is the cytopenia is in the duration of the 1 to 2 weeks. There is a fever is there along with the lymphadenopathy. Then in that scenario, you should think from the viral infection also, particularly the infection and the CMV. They can sometimes present with the pancytopenia along with the lymphadenopathy. But yes, the careful peripheral smear examination is clinch the diagnosis whether I am dealing with the case of viral infection or it is the leukemia. Then subsequently the bone marrow activation give the answer.
Yeah, the bone marrow is hypoplastic, sir. The bone marrow is hypoplastic. Multiple lymph nodes, LDH of 6,000.
You have to do the bone marrow biopsy. If it is bone marrow biopsy, there is no abnormal cell is there. Then sometimes the viral infection induced cytopenia means there is a viral induced pancytopenia, and the viral induced hypoplastic might be the differential diagnosis. Because sometimes the viral infection, particularly Epstein-Barr virus, they can create it with the hypoplastic marrow. Sometimes the hepatitis infection, particularly hepatitis A and hepatitis E, sometimes they have an infection that can lead to pancytopenia and bone marrow, maybe the hypoplastics.
Thank you, sir. Anybody else has any question for Dr. Tufan, sir? Yeah, Dr. Nishad, your question.
Yeah, sir. Pancytopenia because of hypoplastic MDS and pancytopenia because of aplastic anemia, especially if it's an elderly patient, sometimes poses a big challenge how to differentiate between the two. Obviously, there are karyotypic abnormalities in MDS and other factors which differentiate. But still, I would like you to throw some light on this picture, sir.
Hey, I think this is interesting question. I already given some answer, but yes, the peripheral examination has to be done by the expert pathologist or the hematopathologist, because sometimes you can get a dysplasia on your peripheral blood smear itself also. That means dysplasia and the erythrocyte dysplasia will be also the myeloid series will be there.
We have lost you again, sir. So
in that group of the patients, I think the dysplasia thing is very, very important. You should consider for that. And then the bone marrow aspiration and the bone marrow biopsy give the answer in these cases. So as you rightly pointed out, and also the previously the another have been given that same answer, that hypoplastic MDS and plastic anemia sometimes it's very difficult to differentiate. But dysplasia and also the cytogenetic abnormality and nowadays the molecular abnormality sometimes give the differential diagnosis. Dr. Amit, please.
Yeah, thank you, Dr. Nishad. Another question which has just come up is about how do you treat a case of copper deficiency, your bone marrow findings in a case of copper deficiency, pancytopenia, and a patient who has undergone a bariatric surgery, and how do you overcome that and how do you treat that condition? Copper deficiency, pancytopenia,
the rare entity.
Yeah, bone marrow findings.
I think there is no specific finding of the copper deficiency in that case. You have to diagnose for me with the analysis of the blood, particularly the serum copper level has to give the answer. The bone marrow finding is more or less similar. So in that scenario, you have to supplement with the patient with the copper. That is the copper preparation sometimes is available, sometimes is not available. And sometimes the multivitamin that contain the copper has to be given in the therapeutic doses. But yes, it is the very, very rare entity, and in my career, I only came across only the 2 cases that can present with the copper deficiency with the pancytopenia. But it is a very, very interesting work.
Thank you, sir. Anybody else has any other question for Dr. Tufan, sir? Yeah, Dr. Sandeep Bartake has again raised the question. Yeah, please.
Somebody asked about copper bone marrow findings in copper deficiency. So you do get vacuolated myeloid, erythroid and myeloid precursors in that. And if you do the iron staining, so plasma cells will show the iron stain. So these are findings in copper deficiency, and sometimes it is confused with MDS. So that has to be kept in mind.
Right.
Thank you, Dr. Sandeep. Anybody? Any questions for Dr. Tufan, sir? Well, I've finished all the questions from the chat box. And if no other question by the discussion, sir. Well, thank you so much for joining us, sparing your time this Saturday evening. And you had a very busy schedule today, I know that. You provided a re-recorded video yesterday only. Thank you so much for being with us. You're always wonderful, always good to hear to you. Absolute, very crystal clear lecture. What an approach to pancytopenia. I think very, very useful for everybody, mainly for residents as well as for hematologists also. Thank you so much for being with us, sparing your time Saturday evening. And
so, thank you, Dr. Amit and the Mumbai Hematology Group and all the audience for giving the opportunity. And thank you very much and good night to everybody.
Thank you, sir. Thank you so much. And I thank all the discussants for joining over here, spending your time this Saturday evening. I thank all our audience over here to join here this Saturday evening. Meet you tomorrow, Sunday, with another interesting webinar from 11:30 a.m. I now hand over to Mr. Prashant Agarwal for the final vote of thanks. Thank you so much for being with us. Thank you. Thanks a lot. Dr. Prashant, screen is yours. Please go ahead.
Yes, thank you. Thank you, all of you. And we want to take a moment to express our heartfelt gratitude to each and every one of you. We also extend our sincere thanks to our speakers and panelists who graciously shared their insights and experience. Thank you very much and good night to all of you.
Thank you, Mr. Prashant Agarwal. See you tomorrow at sharp 11:30 a.m. Thank you, Tufan sir. Thank you all the discussants. Thank you all the audience. See you tomorrow 11:30 a.m. with another interesting webinar. Bye.
Thank you.